Welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, October the 8th, 2025. So thanks everyone for joining. On the call with me today from the STSI, we have myself, Emily Conrad, we have Nancy Honeycutt, Banu Yatsi, Paul Meehan, and Ruth Raleigh, our GTSD Clinical Consultant. So thanks everyone for joining. As usual, I'll just provide our STS updates and then I'll turn things over to Ruth for our data manager education portion for today's webinar. And then we'll finish up with Q&A. As always, if you have questions, just please submit your questions via the Q&A function, not into the chat. Also, if you would rather just ask your question, the raised hand function is enabled. Just be sure to ensure that the microphone is enabled on your end. So let's go ahead and get started today. For our STS updates, our fall 25 harvest, which includes the surgery dates July 1, 2022 through June 30th of 2025. Those analysis results, the analysis has been completed. The results are currently being reviewed and tested by myself and some of our core group members. And we anticipate they will be available next week for you all. So we will send the official email communication once those results have been posted and are available for you all. So I do anticipate, barring no crazy issues or problems on the IQVIA side with the upload, I don't foresee those going out first of next week. And again, we'll send that official communication once those results are available for you. The 2026 harvest dates, several people have asked for those. Nancy and I are meeting this week and we will finalize the 2026 harvest dates. We expect, we should have those posted next week, early next week on the STS website. So those 2026 harvest dates are coming soon. Also, if you were not aware just yet, but the draft 5.26.1 data collection form is posted and out on the STS website. And here, of course, is just where you can find the draft form. And again, please note that it is marked as draft, mainly for version control purposes. Our vendors are in the process of certifying. So once our vendors are certified and we see that there aren't any major issues, no tweaks or need to be made, that form will be finalized and will be re-uploaded on the website. So just a reminder that the 5.26.1 data collection form should only be used with OR dates of January 1, 2026 forward. You should not be using this form for any surgeries that occurred prior to January 1, 2026. Again, as I just stated, the vendors are currently updating their software and will begin certifications in the coming months. And Ruth and I will be holding upgrade webinars, planning for them to begin early November. We're working on this schedule. Exact dates and times will be coming soon. And once we have those dates and times finalized, an email communication will be sent with the webinar details. Ruth and I are currently working on the training manual for 5.26.1. So hopefully that will be available, hoping December, early December. So we've got a lot of work to do and working on it. So hopefully we can get that out to you all in December. There was something else I wanted to say about the data collection form and the new version, but I cannot remember what it is at this time. So I'll circle back if I remember. AQO, so just wanted to give a quick shout out. Thank you to all of our attendees and our speakers. Thank you to everyone that participated in this year's AQO. It was so great to see many of you in San Antonio. So I apologize, I was not able to be in two places at once this year. So Ruth and Carol led the GTSD session while I worked the congenital session. So again, it was great to see everyone in San Antonio and to catch up with many of you. So hopefully next year, if you weren't able to make it to this year's AQO, which I should have put a slide in here and I did not. So I will add that prior to posting the slides on the website. Next year's AQO will be held in New Orleans. So it will be on September, Emily, correct me if I'm wrong, 23rd, 24th,
Yeah.
25th. Oh, those are the
Yeah.
dates. Okay.
Yes.
So our GTSD and CHSD sessions will run concurrently again on the 23rd and 24th. So each session will have a day and a half. Each database will have a day and a half for AQO next year. So our first day, the 23rd, will be full of content, and then on the 24th half day will be breakout sessions. So each database will have breakout sessions on the second day of AQO for CHSD and GTSD. So we hope you are able to join us next year in New Orleans. More information about next year's AQO will be coming soon. And again, I'll throw in another slide prior to posting this. This year's AQO, if you were not able to attend, or if you still have not purchased a virtual pass and you are interested in the content from this year's AQO, the virtual pass is still available for purchase. I've included a link here where you can purchase that virtual pass, and the last day to purchase is November 21st. So if you are interested, please be sure to purchase prior to or no later than November 21st, as it will not be available after that. The reason being is due to it's about a month prior to the deadline for claiming your continuing education credits. So that November 21st still gives you plenty of time to review all of the content online and get your evaluations in time to get your continuing education credit. So again, the last day to purchase this virtual pass for this year is November the 21st. Post AQO content availability. If you were in person, you've seen this information before, but for just a reminder, so recordings of the live sessions will be available early October. Emily is working to get the remaining of the GTSD content posted. I believe she said she's got about half of it uploaded to the meeting platform as of today, and hopefully the rest will be available later today or tomorrow. But the recordings are available and will remain on the virtual platform until mid-December. After mid-December, all of that content will then move over to the STS Learning Center. Once that content moves over to the STS Learning Center, you will have access to all those PowerPoint slides, handouts, case scenarios, and videos until AQO of 2026. All right. Speaking of CEs and CEUs, don't forget to view all of that on-demand content and the live content prior to completing your evaluations. You must complete the evaluation at one time, so you cannot leave and return to the place you last commented. So please be sure you viewed all the recordings and all of the on-demand content if you're using that virtual pass. If you are in person, please ensure that you've viewed all of that on-demand content prior to starting your evaluation. And the deadline to claim that credit is Friday, December the 26th of 2025. So again, just make sure you get that those evaluations, and the deadline to claim that credit is Friday, December 26th, 2025. AQO, our GTSD Hot Topics webinar. The Hot Topics webinar is planned for November the 3rd, 10 a.m. Central to 2 p.m. Central. We will be bringing back some select speakers and provide additional opportunities for Q&A. So for all of our virtual attendees and also for our in-person attendees, if you have questions about any of the presentations, please come back and join us for our Hot Topics webinar, and we will try to get as many of those questions answered as possible. Ruth and I are still working on the agenda for the Hot Topics webinar, so all of that information will be included in upcoming communications from our marketing team. So just be on the lookout. And again, that webinar link and the agenda will be included and sent via email from our marketing team in the coming weeks. So just be on the lookout for that. All right, that's all that I had. I saw a question. Can you repeat the info about next year's AQO? So yes, Sorry about that. I spoke a little quickly. Next year's AQO will be held in New Orleans. It will be September 23rd, 24th, and 25th. The GTSD and CHSD sessions will run concurrently as they did this year. Each database will have a day and a half of content. The GTSD session, again, the CHSD will be on the 23rd and 24th. The 23rd will be a full day of content for GTSD and CHSD. The second day, the 24th, will be a half day of content. That will be our breakout sessions. So I believe the hour, it was at 8 to 11, Emily?
Correct.
Okay, yeah. The second day will be from 8 to 11. And again, I'll put all of this information in a slide and include it prior to posting this slide deck on the website. So our second day will be a half day from 8 to 11 for our breakout sessions for next year's AQO. It'll be our first time doing the breakout sessions for CHSD and GTSD. We did it this year with adult cardiac, and Nancy and Melinda did an amazing job. It was really good. We got a lot of feedback, a lot of great feedback. It was very well received this year, so we are looking forward to incorporating that into GTSD and CHSD for next year. All right, so next I'm going to turn everything over to Ruth for our STS education.
Thanks, Leanne. Full disclosure, this is a presentation that I put together for the Michigan data managers previously, like a month ago. So for our Michigan data managers, I apologize for the repeat content, but I thought that your questions were great and the case examples that you gave me were incredible. And so I wanted to share that with the data managers across the rest of the country. So thank you so much for your thoughtful questions and all of the incredible work that you do in the state of Michigan. And for the rest of the country's data managers, it was incredible to see so many of you at AQO. It was really nice to put names and faces together. It's my favorite day of the year when I get to see everyone in person instead of just being voices behind initials and names on screens. So thanks to everyone who could attend AQO, and hopefully looking forward to seeing more of you next year. Okay, with that, we're going to start by talking a little bit about case inclusion, just very, very quickly. Going to go to the next slide. So remember that we only include new lung and esophageal cancer cases that have a therapeutic resection in the database. If you enter cases that are not new lung or esophageal cancer cases, then when you get to the sequences asking you whether this is a lung or esophageal cancer case, you need to say no to that question. If you're entering optional cases, if it is your intent to only enter required cases, you don't even have to do that. Just put it in if it's a new lung or esophageal cancer case. Some preliminary information that's coming back from the audit, actually we just met to start looking at that this morning, is that particularly in the esophageal cancer space, we're struggling with only capturing new esophageal cancer cases and some recurrent esophageal cancer cases. Some salvage procedures are being entered in the registry. So I'll put together some specific examples of esophageal cancer cases that would and would not be included for our next webinar. So remember, you're going to exclude diagnostic procedures for patients with, again, recurrent cancer. So patients that have previously been definitively treated either with a resection or chemotherapy, radiation that was not induction chemo RT, but rather, chemo RT provided with the intent of curing that patient's disease. Patients previously treated with SBRT, which is called CyberKnife at some sites. I think there might be some other sort of branded names for that. And then patients whose final pathology is not lung or esophageal cancer, even if the thought going into the OR was that, yes, this patient's going to come out, lung or esophageal cancer. If it's not, then you don't have to include the case. The one exception to that being if your patient had induction therapy and there was no disease left at the time that the resection occurred because the induction therapy was so successful doing its job. So those are all of the exclusions. This does include, like I said, patients that go to the OR with a lung nodule, that final pathology comes back as lung cancer, and the resection is considered therapeutic. Gonna go to the next slide. What about incidentally resected lung cancer, which is always a hot topic for the current version? Cancers that are therapeutically coincidentally resected must be entered. For example, if a surgeon wedges out a lung nodule during a cardiac case and the final path is positive for lung cancer, no additional treatment is going to be rendered for that lung cancer, that case would be included. The only exception, which is outlined in the training manual, is the incidental resection of cancer in explanted lungs for transplant. This guidance may change with the next version. So as we consider as we pull together the training manual for the next go round, we will be sure to specifically address this in the training manual. We're going to do a lot of cleaning up of the current training manual to hopefully make things much more concise and clear for everyone. A new training manual is like a beautiful thing. I'm going to go to the next slide, please. Okay, so here is a question. So this is a question that was received. I have a thoracic case. They made the initial incision. The patient arrested. The procedure was aborted. Other than making the initial incision and then closing the incision, that was all that happened. That case is excluded, correct? The patient's surgery was rescheduled. This data manager was correct. The case would not be included. The only time this would be included would be if the patient had died and an analyzed procedure was being performed. That case would have been required for entry for the primary procedure. And that very specific case where a patient died having like a lobectomy, for example, would be that you would enter the lobectomy as a primary procedure and record the intraoperative mortality, even if the only thing that happened was the primary incision or whatever. And then that FAQ is pasted on the slide for you. Next slide. Next question. So lung cancer was suspected. The patient had a diagnostic wedge. The frozen came back. The intraoperative frozen came back as non-cancerous. Therefore, no further resection or any node sampling was done. The final path report came back with a diagnosis of lung cancer, however. Should this case be included in the registry? I feel like once the intraoperative path came back, the intent of the resection was diagnostic and therefore should be excluded. No further resection is planned. This was a question that went to the core group, and the core group felt like this should be captured in the registry as a therapeutic wedge resection because no further resection was planned. And ultimately, this was a curative resection for this patient's lung cancer. A quick note on core group. The core group has not met for a couple of months. The surgeons' schedules have been really challenging for Leanne to coordinate. We are planning to meet this week on Friday, so I know there are quite a few people waiting for questions to be answered by the core group. I apologize for the delay, but you should have answers shortly. Next slide. Okay, I'm trying to determine if this case should be included. The patient has a complex history of recurrent squamous cell carcinoma in the neck, tongue, like head and neck cancer, and the patient had a new right lung nodule concerning for malignancy and had a wedge resection. The pathology report says lung tumor could represent metastatic squamous cell from the tongue. The tumor shows similar morphology to this lung tumor. The staging protocol completed in case it is lung primary. So the staging was completed just in case it was lung. The doctor in the office visit after surgery stated that they strongly suspected it was metastatic from the head and neck disease and less likely lung primary. This is really a question you're going to have to talk through your surgeon to determine if this case should be abstracted as a primary lung cancer or excluded as metastatic disease, because the language in their note is leads one to a conclusion, but certainly isn't definitive. Also, you can always check your oncology notes to see if it was managed ultimately as metastatic versus primary disease. Another thing that came up in the audit conversation that we had earlier today is a question about how data managers should be tracking these conversations that they're having with their surgeons offline about questions such as this. I think different data managers do it different ways, and there's not really a best way to do it as long as you have access to those conversations for the purposes of audit. So if you are a paper person and you want to send emails and print your emails and throw them in a folder by year, that's fine. If you want to copy paste your conversations into an Excel spreadsheet organized by year and month, that's totally fine. If you want to just create an email folder and dump all of your like audit backup support emails into that folder, that's fine. If you're having conversations by via haiku, it's just important that you're able to find those haikus and provide them to auditors when you submit all of the information for your cases. So however you want to do it is absolutely fine. Just create a process that works well for you as an individual. You want to go to the next slide, please? Okay, we're going to talk a little bit about synchronous primaries, which is everybody's favorite topic. And go to the next slide. So the goal was and will remain in the next version to capture the data that most impacts your patient's outcomes without collecting data that is unnecessary. I think the request from a lot of data managers as we went into this version upgrade again was to like create a way so that you could enter the data for every single synchronous primary that was resected on the same encounter. The surgeons really did not feel like that data would be valuable, and it would just be you spending time entering data that wasn't going to be used, which they feel very strongly about only wanting you to spend your time on value add data. So it's going to remain the same. You should always code your most invasive procedures, your primary procedure, the final path of lesion most likely to impact your patient's long-term survival, and then provide the clinical staging information as directed by your surgeon. In some cases, it's going to be nice and neat for you, and sometimes it's not. So for example, a patient with a right lower lobe wedge and a right upper lobectomy with more aggressive pathology in the right lower lobe, your primary procedure is going to be the lobe because that's the most invasive procedure. The final pathology that you're going to enter is that right lower lobe wedge lesion. And then for clinical staging, if it's not, clear how that should have been clinically staged, you might have to have your surgeon help you out in terms of clinically staging the patient. Clinical staging, whenever possible, should be taken from your surgeon's notes. If your surgeon is not putting clinical stage in the note and you can't get them to put clinical stage in the note, then you can use the information in the training manual to ascertain the clinical stage. If you are looking in the training manual and you feel like the clinical staging information in the training manual is conflicting with the clinical stage provided by your surgeon in their pre-op HMP, please clarify with your surgeon if they made a mistake in clinical staging, or if you made a mistake in clinical staging, or why there is that discrepancy, and then enter the correct clinical stage. Clinical staging can be very nuanced for some subsections of lung cancer. Sometimes it's like easy peasy, you can do it in a snap of a finger, but sometimes it's really, really tough and takes a lot of practice. So whenever possible, be sure you're using your surgeon's clinical stage. And as always, I feel like I say this every webinar, continue fighting to get them to put that in their templates so you have that information. Or like at the top, my surgeon puts it in her pre-op HMP, and then also she'll put them in the top of the op note. It always includes the patient's clinical stage. And then the PAs also always include the clinical stage in their rounding notes. So it's in a lot of places and it's always very consistent from note to note. So really if you can get it in any of those places, it's a huge win for you. If you want to go to the next slide. For the next version, the new sequence synchronous primaries resected will be there. It's a simple yes, no. And like I said, not going to collect more data than that on synchronous primaries. Next slide. Another area where a lot of people struggle is diagnostic versus therapeutic resections. This can be tough. So it takes practice. Operative notes and isolation can be misleading. I think some surgeons call everything diagnostic at the beginning, even though at the end it becomes therapeutic. So you really got to read your post-op visit notes, your oncology notes, etc. If you can't figure it out, be sure you're asking your surgeon. And again, this is one of those things that if you need to document it for the purposes of audit, create a system that works for you. Next slide. So here's a couple of examples. So this patient was scheduled for a left lower lobectomy for biopsy proven left lower lobe, a non-small cell adenocarcinoma. They had neoadjuvant chemo with post-treatment PET. During the case, there were several areas of abnormal appearing tissue. along the pleura and the diaphragm. Multiple biopsies were sent. They took some lymph nodes, they resected some lymph nodes. The surgeon did noted a nodule at the base of the lingula and did a diagnostic wedge of this. The frozen returned malignant with malignant cells of the pleural biopsies. And so he decided not to do the left lower lobectomy. So they wanted to know how to code that. Would it be called lung cancer? If so, is it a diagnostic wedge or a therapeutic wedge, et cetera, et cetera. So ultimately, like from what was provided by the SATA manager, it sounds like the surgeon decided that while they intended to do a therapeutic procedure, it wasn't possible because of the extent of the disease when they opened this patient's chest, and they were no longer a candidate for a therapeutic resection. At that point, you don't need to enter the case. If you choose to enter it, of course, you can enter it as a diagnostic wedge. It's going to be thrown out of analysis. You're going to say, no to lung cancer because you don't have surgery with curative intent. If a case isn't analyzed, you really have some flexibility. And I get a lot of questions in the FAQ inbox about cases that aren't going to be analyzed. I would say try to be consistent with the way that you have entered your data in the past, because really the primary purpose of that data at this point, when it's a not analyzed case and not part of the optional modules, is for your institution to use internally. So it's less important, I guess, if you have like all of the procedure codes, for example, for a non-analyzed case, because the STS is not going to analyze those cases, and it's not, and again, not part of the optional module. So feel free to you know, work within the training manual, but not be as stressed out about, I guess I would say, for the non-analyzed cases if you're choosing to enter those. Next slide. Anastomotic leaks, a few slides on this. So post-op upper GI, the impression, so it says in the impression, maybe post-surgical change or mucosal redundancy. Leak cannot be completely excluded. Consider short-term follow-up. No evidence of leak at the pyloromyotomy. Post-surgical changes, the impressions, post-surgical changes, a couple days later, post-surgical changes, anastomosis of remnant esophagus without evidence of leak or stricture. In terms of treatment, the patient remained NPO after it came back as maybe a leak. Same day, surgical oncology wanted to hold off due to the potential leak. And then on the 12th, the patient proceeded with sort of like the normal post-operative sips of water and ice chips. If you want to go next, I think, yeah. So is this a leak? No. Radiology hedged their bet. There was never really a leak definitively diagnosed. And radiology wasn't clear. So basically they were deferring to the clinician who's actually seeing the patient and seeing how they're progressing to sort of make that declaration essentially on the 10th. They decided to treat sort of conservatively, and by the 12th, both the imaging was clear and the patient proceeded. So no leak care. Next slide. Here's another long series of radiology reports, but I think it's helpful to look through these. So initially on the 29th, this patient had no evidence of a leak. On the 30th, it said that there was a suspicion of a leak. On the 3rd, there was no evidence of a leak. The patient, from a treatment perspective, had a chest tube placed, remained NPO, was given some Botox, and then ultimately on the 8th, clear liquids were started. Go to the next. For this one, it's really hard to tell. I would have to talk through this case with my surgeon to really understand, like, does this patient have a leak or does this patient not have a leak? It's really tough to necessarily figure out if there's a leak or not, just trying to read through radiology reports. If you go to the next slide, Leanne.
Now I got it. Sorry about that.
That's okay, no problem. A lot of times it's because radiologists are hedging their bets because it's really hard to tell some of these things just on imaging. And so you might have to just talk through some of these really tough, is it a leak type scenarios with your surgeons to elucidate the answer to that question. Next slide. This is a tool that was shared by one of our data managers. Start working with your pathologist now if you're commonly missing information in your pathology reports. And Leanna Emily, she sent a few of these, and I would love to get them posted on the website. I don't know if that's possible to share with other data managers, but I think the way that she has these conversations templated is very, very nice. And even if you don't copy paste exactly her template, I think you'll make great headway with your pathologists and getting the information you need in the pathology report if you're like hitting them with the same verbiage over and over because they're going to get sick of getting the same email.
Okay,
So
yeah,
we'll try to get those posted in the next, I don't know, week or so. Fair?
yeah, absolutely. We'll work with marketing and get those posted.
Okay, thanks. Um, this is really just so you can go uh, online and download this free tool that talks through nodal staging. I think it's a great resource, especially for newer data managers. So feel free to grab that link and grab a copy of this diagram. It's really, the next version is super oncology focused, and you're going to need to brush up on all those oncology skills. Next slide. I think that's it. So thank you all. Happy to answer any questions.
Yeah, so we do have some questions. Let's go ahead and tackle those while we're waiting for a few to come in, a few more to come in, if needed. And Wilson, they were asking, what if this case came back for a lobectomy after the positive finding? I think this was either the second case inclusion or third. I'm not sure if you could just clarify if it was.
I think I know, like I
Okay.
can kind of re-summarize.
Okay.
So if you have a case that goes to the OR and they do, it was the one where they assumed the intraoperative findings came back as negative. So they thought they were doing a diagnostic wedge that was negative, but then ultimately it came back as positive. If they then took that patient back to the OR for a lobectomy, the initial wedge resection would not have to be entered because it's diagnostic at that point, and the lobectomy becomes the therapeutic treatment, which I know is a little bit confusing, maybe. Trying to think of the best way to explain it. So if a resection is done and the patient has no further treatment to cure that disease, then it's considered uh, therapeutic. Although I'm gonna hedge my bet on that one because sometimes patients will have like adjuvant chemo RT. Hmm. I mean, ultimately, a wedge resection followed by a lobectomy, like the lobectomy is always going to be the therapeutic procedure in that case. A wedge resection not followed by a lobectomy can be either diagnostic or therapeutic, depending on what happens next, I guess is the best way to say it. And I'll try to think of a better way to put it into words for the next training manual or the next webinar. That's a great question, Nancy. I appreciate it.
All right. Our next question from Heather. Do I include upper GI endoscopy, McEwen, thoracoscopic, mediastinal lymphadenectomy, J-tube? I'm just gonna be literal with this. ICG angiography of stomach conduit and by surgical oncology in same OR setting. Left thyroid lobectomy with intraoperative nerve monitor. If so, can you confirm coding, please and thank you. That was very tough on my non-clinical brain. That was challenging.
Yes, Heather, I'm gonna type my email in the chat. If you can just email me that, because I'm not gonna have all of those CPT codes at the ready. But I can get them to you later this evening.
Okay. Next, let's hop down to the rest of our clinical. If you've already entered the formerly thought of as therapeutic wedge, but then had a therapeutic lobectomy, if you have to delete the entered case, you have to delete the entered case that was formerly thought to be therapeutic wedge resection, correct?
Correct. Or you have to change it to diagnostic.
Okay.
I would just delete it though. That's my personal preference.
Will there be a virtual option for next year's AQO? Emily, are you still on or?
I'm gonna say we have not discussed at this time,
Okay.
and we'll be able to provide an answer in the spring.
Perfect.
I just can't say yes or no either way. It's what we've been doing, but I don't want to say anything incorrect.
Sure. Sounds good. All right, thank you. Patient has suspected leak and they placed stent, but no leak was observed during EGD. How do we capture this?
I would ask my surgeon to clarify if the patient did or did not have a leak and then capture it as they direct me to do.
Sounds like a plan. Mary, you had your hand raised. I don't know if you had a question. Miss Mary Cook. I don't
The
know if
only
you
thing I'll add while we're waiting for Mary, sorry, can I add one
Yeah,
bit?
sure.
I would also look before I ask my surgeon, I would look to see in the like patient's discharge summary, like, does it say like an anastomotic leak in there anymore? Or does like, look at all of your notes, look at your discharge summary, your 30-day office visit, like all of those different spaces and see if anywhere someone definitively diagnoses that leak and doesn't just say that it was suspected. If it's definitively diagnosed as being like present anywhere, I would capture it. But if all it ever was suspected and treated, then I would ask my surgeon to clarify ultimately that there absolutely was not a leak, that they treated on suspicion.
Got it. Sounds good.
Oh, Mary doesn't have a question.
No, no worries. No problem, Mary. Dion, patient had pre-op air leaks, went to the OR, air leak resolved, but returned. Chest tube inserted, and for a period of 20 days, intermittent air leaks persist, some lasting greater than 5 days. Since air leak was presented pre-op, should this be considered post-op comp? Surgeon wanted me to clarify, as this is a question strictly for him.
I would be curious to know what the procedure was that was performed. It's unusual for a patient having a therapeutic lung cancer resection to have pre-operative air leaks. If this is like a non-analyzed case, I think there's some latitude because really you're capturing that case for your surgeon, right? At that point, or your institution.
Yeah,
Um,
Dion, did you want to clarify?
Can you hear me?
Yes, ma'am.
yeah.
Okay. So there was a patient that went in May for a right upper lobe lobectomy.
Mhm.
Her 30 days was up. She didn't have any complications, but later on down the line, she was having shortness of breath. They took it in, found the air leak, found the pneumothorax and something else. I can't remember. They inserted a chest tube. So for a few months, she was at home with a chest tube. She continued with the persistent shortness of breath, and then they went in and found out that she had an air leak. So on last month, they went in and inserted another chest tube. That air leak resolved. So they clamped off the first chest tube, removed that one, and then she started having more shortness of breath. They did imaging. They reinserted the chest tube because they found out she had more issues. So they're trying, and then that chest tube kept having intermittent air leaks. So they're trying to figure out, even though this case is not analyzed anymore, she's already in the system, but they're just trying to figure out, do they consider this as a air leak? It's not something I'm entering anymore. It's just strictly a question from them.
I see. It's like a theoretical question because
Yeah, it's a
it was
theoretical
like
question.
more than 30 days and the patient wasn't still in the hospital. So this is not going to be a post-op event for your lung resection.
Yeah,
But
for her case in particular, but for
yeah,
them as an educational for the resident, they're trying to get them to understand why they are considering it an air leak. But according to the manual, anything that's presented pre-op is not. But then she was having intermittent air leaks throughout her 30-day stay, months after her initial resection.
I mean, I would not capture that as a post-operative event in that case because the reason the patient went to the OR was for the air leak.
Mm-hmm.
But I'd have to think about it. It's not anything that would be analyzed, so
Right. And
it's,
that's what I told him. I said it's not analyzed, so you can capture it on your end as educational purpose, but it's not something STS would see because
oh,
whole 30 days is already up on my end. So it's not something I
right,
have to capture, but they were just
right.
reviewing the case and they were confused as what is presented in the manual versus what he's telling the resident.
I mean, I think you have to remember that the training manual is really focused
Right.
on, you know, pulmonary resection for lung cancer, esophageal resection for esophageal cancer.
Right.
And so the way that the training manual is written is to really focus on developing short and long-term outcomes for that patient population.
Right.
This patient, or patients that go to the OR for a lot of reasons, patient, whatever. It's hard sometimes to apply the training manual to those cases because it's not what it's written for.
Right.
To some
Right.
extent.
Yeah.
Okay. I'll let him know. Thank you.
Yeah, sorry. And if I can help more, let me know.
No, you're fine because I was confused and he's the champion, so he's confused. Hey, you
No,
don't
you
know,
tell
I don't
me.
know. We have a meeting tomorrow. I can ask them.
Thanks, Dion.
Thank you.
Oh, no
Yeah.
problem. All right. AH, your hand was up. That all I see is AH. I don't know. I don't know if that was by accident or if you had a question. You can unmute if you had a question. Going once, going twice. Okay. Oh, nope. Okay. All right. Just while we're waiting for any additional questions, our next monthly webinars are scheduled for November 12th at 2:30 Eastern and December 10th at 2:30 Eastern. I suspect as we're working on our educational webinars for the new version, those webinars may get utilized for that purpose. Again, more information will be coming very soon about the upgrade webinars. As I mentioned earlier, our AQO Hot Topics webinar is scheduled for November the 3rd at 11 a.m. Eastern, 10 a.m. Central. My contact information, if you have any questions, with the harvest reports and analytics being released next week. Again, that official communication will come out once those reports are available. If you have any questions at all about those reports, please email stsdb_helpdesk@sts.org. Please do not email me directly. I do not have access to reports or to everyone's reports. So please, first line of questions, if you have issues accessing your report, or if you have questions related to the numbers in the report itself, please, again, just reach out to stsdb_helpdesk@sts.org, and Paul and Banu and team will be able to assist you directly. If they're not able to answer your questions, they will forward them on to either myself or our analytics team. So again, just please, first line of communication should be, first point of communication, point of contact should be our help desk at stsdb_helpdesk. If you have any database operational questions regarding your database participation or invoicing, things like that, you can reach out to our team at stsdb@sts.org. All right. I am not seeing any additional questions come in. Like I said earlier, before I put these slides out, I will add that slide about 2026 AQO with all the details. So again, I apologize for not including that here in my initial slide deck. So I'll get this slide deck updated and over to our marketing team. So everything should be posted hopefully by the end of the week or first of next week. If there are no additional questions, I'm not seeing anything. Ruth, Emily, Paul, Banu, does anybody have anything they wanted to share before we hop off? Oh, Dia has one question, so hold that thought. Right upper lobe wedge resection, right upper lobectomy, which is marked as primary thoracotomy with wedge resection or lobectomy. Sorry, got on late and seeing if something changed.
Hey, no, nothing has changed. The lobectomy is still going to be your primary procedure. You always want your most invasive procedure to be your primary.
Yeah.
Because your most invasive procedure is going to mostly influence your patient's short-term outcomes. less so your long-term outcomes, I think is what they're finding. But certainly a bigger impact on the short-term outcomes.
Perfect. No problem. Thank you, Dia. All right. Well, thank you everyone for joining today. If you have any questions, please feel free to reach out. Thank you, Ruth and team, for joining today. And with that, I hope you all have a great rest of your week. And we'll see you all soon. Reach out if you have any questions. Thanks, everyone. Hope you all have a great week.
Thanks, Ann.
Thanks, everyone.
Thanks, Ruth.
Thanks, Ruth.